Aloha guys, Dr. Tom is coming back at you. Pay no attention to this black screen in the screen. It's just that way in the PowerPoint. I don't know why. Okay, we're going to finish up the respiratory system. We ended here last time, so we're moving along here. Okay, in a nutshell, of course, the big thing that the respiratory system does is it transports the blood gases, oxygen and carbon dioxide, throughout the body. The amount of each gas expresses a partial pressure, which is what PO2 and PCO2 mean. Let me say this real quick, guys. Carbon dioxide is a waste product of cellular metabolism, but it also is very important. We have to have a certain amount of it in the blood to balance the pH. So you can get sick, or even worse, if you don't have enough carbon dioxide, or if you have too much. So carbon dioxide is very, very important. It's a waste product, but it also balances the blood pH and the body's pH. Okay, oxygen is transported almost entirely as oxyhemoglobin. You know what hemoglobin is. However, carbon dioxide, 70%, is transported as the bicarbonate ion, which is what HCO3 is. 20% transported as carbaminohemoglobin, and 10% dissolved in the blood plasma. So in the case of CO2, more of it is transported as the bicarbonate ion than it is in hemoglobin. But all this is real important. Okay, now this is a little bit confusing. Okay, we're going to talk about each one of these. It looks. Let's see. Let me see how I can make this easier. Okay, we have this enormous total lung capacity. This is in liters, 0 to 6 liters. How much is 6 liters? It's a liter is half of a 2-liter Coke. Okay, so the entire lung capacity, which we cannot utilize, is this enormous amount of 6 liters. Vital capacity is this amount. That's as much as we possibly can take in and as much as we possibly can do. Exhale every tiny little bit. That's what that is. However, the amount of air that we use for normal breathing is called tidal volume, like the tides. And it's this little bit right here. We use about a half a liter when we're like now, just sitting here. But we always have an inspiratory reserve. We can inhale up to this much, or we can exhale down to this much. The residual volume of 1.2 liters is the amount of air that's in the respiratory tract after we've exhaled every last tiny little bit you can. If somebody laid $1,000 down and said, I want to see you blow out more air than that, you would not be able to do it. Okay, so tidal volume is normal, quiet breathing. Let's go on to our next one. Lung capacities. Vital capacity, which is this one. Maximum exhalation followed by the maximum inhalation, as much as you possibly can do, is this. Remember, you can't get down below the residual. The functional residual capacity is, where is it at? Is the amount you can force, and in total lung capacity is just the total amount from 0 to 6 that you can inhale. But the only kind you can actually use, guys, basically, normally is this, but you can use the vital capacity from here to here. If you take the maximum that you possibly can inhale and exhale out the maximum you possibly can exhale. And remember, there's always some. It just keeps everything open. The bronchial tubes, the lungs, and so forth, always have this residual volume of air. And again, this is in liters. Okay, control of breathing. Well, part of it's chemicals. We have chemoreceptors at different places in the body that monitors the amount of oxygen. The partial pressure of CO2 and the amount of hydrogen ions. Remember, this is what determines how acidic something is on the pH scale. Are major regulators. Chemoreceptors. There's the central nervous system, and then out the carotid bodies, which are in the neck. And the aortic bodies, which are in the, let me guess, the aorta, monitor the amount of oxygen. All this sort of thing, guys, is controlled by the brainstem. The medulla oblongata controls this, main control center for breathing. Inspiratory and expiratory neurons are there. The pons, which is also part of the brainstem, modifies and controls breathing patterns. Pneumotaxic center, P is silent, regulates the amount of air a person can breathe and take into the body with each breath. Apneustic center controls the intensity and rate of breathing. So what controls the actual function of the breathing, of course, is the brainstem. In this case, the medulla and the pons. And then there are these peripheral and in the CNS monitors that monitor the amount of oxygen and carbon dioxide. Ventilatory rate and rhythm, let's see. Factors, well, emotions like anxiety and fear can make you rapid breathing is part of fight or flight response. Yes. Involuntary, well, chemoreceptors. Central chemoreceptors detect changes in blood concentrations of carbon dioxide and hydrogen ions, as we said previously. Increase in partial CO2 and hydrogen ion increases rate and depth of breathing. Why? To try to get that additional, to bring the acidity down and get rid of that extra carbon dioxide. Peripheral chemoreceptors, again, in the carotid bodies and the aorta, are sensitive to low concentrations of CO2 and hydrogen ions. So the central ones look for too much, and the peripheral ones look for too little. It's all balanced, guys. So what can we say about respiration? Well, we can say that part of it's voluntary and part of it's involuntary. Obviously, when we're asleep or unconscious, we're still breathing, hopefully. But yet we also can vary the rate and depth of our breathing and all too. We can do it, voluntarily. Okay. Like this kid. Have any of you had a baby that would hold its breath when it didn't get its way? And the mother would panic and, oh my God, my little Silas is going to die. No, he won't. He's playing you like a fish. Just let little Silas be, Tupac or whatever you want to call him, and Henry, and he'll start breathing. Yeah. I can remember as a kid, the neighbors, she'd panic and, oh my God, oh, he's doing it again. I know what you're thinking. My God, Dr. Tom, have you no mercy? No, I have little patience with idiocy. That's what I have problems with. Okay, here's the pons, here's the medulla, here's the chemoreceptors, sneezing, coughing, yawning, Herring-Brewer reflex prevents overinflation of lungs, otherwise we might rupture them, blow a hole, and that would be bad. Okay, I think we've talked about that enough. Okay, these respiratory terms are real important, guys. Again, upper respiratory problems are the leading reason that people seek medical care. Back pain is number 2. So normal quiet breathing is called eupnea. Eupnea. Now let me add that sometimes the P is pronounced and sometimes it isn't. I'll point it out to you. So like I'm doing right now. Eupnea, normal quiet breathing. Apnea is when you ain't breathing at all. And of course you ain't going to do that for long or you ain't never going to breathe again. Apnea, cessation of breathing. Dyspnea. Now this one the P is silent. Dyspnea. Difficult or labored breathing. This is a very important one. You need to memorize it right now. Dyspnea, difficult or labored breathing. What could it be due to? Well, a variety of things. Some sort of breathing problems, some sort of heart condition going on. Tachypnea is rapid breathing. Tachypnea. Tachy, I always think of a tachometer in a car. A lot of you may not know what that is. I think tachy always means rapid. Rapid breathing means more than normal rapid breathing. Bradypnea, abnormally slow breathing. Bradyal, means slow. Orthopnea, this is important. Difficulty in breathing that's relieved by sitting up. Ortho means something to do with your positioning. Orthopnea, in other words, if a person's, let's say they're in the hospital and they're laying back and they start having dyspnea, labored breathing, a lot of times you can set them up. And what happens, guys, the lungs swing free. When you're lying down, they lay back against the thoracic wall, and it's more difficult to inflate them. When you're setting up, they hang loose, and then they're more easily inflated. Eupnea, normal quiet breathing. Apnea, cessation or stoppage of breathing. Dyspnea, difficult or labored breathing. P is silent. Tachypnea, rapid breathing, abnormally rapid. Generally. Bradypnea, abnormally slow breathing. Orthopnea, difficulty in breathing is relieved by setting the patient up. Okay. Common respiratory terms. Hyperventilation, increase in the rate and the depth of breathing. Hypoventilation, decrease in the rate and depth of breathing. Hypoxemia is abnormally low concentrations of oxygen, of oxygen in the blood. That can actually, over time, can make the ends of your fingers get what they call clubbing, where they swell like little clubs. I think it takes a while to do that. They measure, of course, guys, the blood oxygen levels are measured very easily. They have a little device that looks like an old-fashioned clothespin that fits on there, and it can measure the oxygen saturation of the blood. Hypercapnia is abnormally high concentrations of CO2 from either not breathing enough, fast enough, or holding the breath. Well, guys, again, everything is a balance. The CO2 has to be gotten rid of, but we need a certain amount of it there. If not, we get lightheaded. You know, when a person starts hyperventilating, what do? They have them breathe into a bag. The reason is when they're hyperventilating, they're blowing off too much carbon dioxide. And by breathing in a bag, they're rebreathing that, and it starts raising it back up again. Balance is everything. Hypocapnia, abnormally low concentration of CO2 from hyperventilation, like I just said, panic attack. I think it's a panic attack because you're taking little short, ineffective breaths, I would guess. Okay. All this is real important, guys. If a patient's not breathing, they are in a world of hurt, or they're going to be very soon. Let's see what else we can talk about. As everybody knows now, the vocal cords are the cutoff between the upper, and they're in the upper, and the lower respiratory tract. Nasopharynx, oropharynx, laryngopharynx. Pharynx, think of the pharynx, guys, as the throat, and the larynx as the voice box. What's the device that separates, or yeah, I guess we could say device, when you're trying to swallow food or beverages down? The epiglottis seals off the trachea. Trachea has cartilaginous rings. They're actually C-shaped. They don't go all the way around. What does it do? It gives it rigidity so it doesn't collapse. I use the analogy of a vacuum cleaner. Look at that hose. It's got those rings on there. Otherwise, guys, when you turn it on, the hose would go, and that would be the end of your vacuuming. It's very important, if you're able to breathe through the nose. At least inhale through the nose. The lungs are very sensitive. And if you breathe through the nose, the hair up in there helps filter out particulate matter and things. It also warms and moistens and conditions the air. So that's important, guys, if you're able to. Going over all that. The thing I suspect that would confuse a lot of you guys is this pressure. Let's see where it's at. I'm still got about a minute. Again, think of the lungs as being balloons inflated in an airtight canister. Okay? So P1 is atmospheric pressure, 14.7 pounds per square inch at sea level. P2 is the pressure inside the lungs. P3 is the pressure inside the chest cavity. If you get a hole here for some reason, either pathological or trauma, the atmospheric pressure comes in and it collapses the lung. A collapsed lung, guys, is called atelectasis with an A. They didn't use that term. They should have. Atelectasis, because there's a confusion in medical terminology. They want to say that a pneumothorax is a collapsed lung. No, atelectasis is a collapsed lung. Pneumothorax is what causes a collapsed lung. Okay? Okay, we're about out of time. Let's see. Here they're pumping it out to equalize it. How do you get a pneumothorax? Well, this is one way right here. All right, guys, look over it, know it, do it, be it. Dr. Thomas signing off.